You all right? Okay, yep.
Cool. Good?
Yep, all good to go.
Excellent. All right. So we're very excited to come in and do some refresh on some fracture management. Yes, it's probably an opportune time to just go through, I guess, some trauma stuff as well, because generally if someone has something fractured, it's going to have been a result of some sort of traumatic event. So, what sort of things do you want to know when someone's come in for a trauma-related event? So someone presents to urgent care and they've been involved in something traumatic that's probably led to a fracture. So what sort of things do we want to know?
That pain?
Yeah, so I want to know their pain. Yeah.
How much you use?
Yep.
Up to 10 or whatever we do.
Yeah, yep, absolutely. So we want to know their pain score as well. Yep. 10, obviously.
Yeah.
Yep. What else do we want to know from them?
What type of injury it was,
Yeah.
crush injury, whether it was a fall, what it was.
Yep. So what's actually happened? So, have they come off a quad bike? Have they had a skiing accident? Have they had a farming accident? Have they fallen off a roof? So what sort of story are we dealing with? So we're looking at, I guess, the main thing being the mechanism of injury. So are we looking at significant? Someone comes off a motorbike 100 k's an hour, that's significant. Or someone falls over in the garden, not as much. Cool. So I want to know a bit of the history. If it is something like a motorbike or a quad bike or a ski or something like that, what do we want to know about that?
What's the speed?
What's the speed? Yep. So we know that the more speed, the more potential of injury as well as something. Cool. So we'll have to ascertain how it happened, the speed and that sort of thing. What else do we want to know about that story?
If anybody else saw it, like
Yep.
any person, or whether they were alone or with somebody else.
Yep. So if anyone saw it, head injuries. So again, that it changes again. Is it some sort of head injury or anything like that? And with that head injury, have they had any loss of consciousness? And that'll sort of dictate where are our priorities. Is our priority their fractured arm, or is our priority their head injury or their loss of consciousness, their mechanism, things like that. So we've got the story all together, and we've got those sort of things. And we looked at their vital signs, because that's one of the first things we're going to do. If we look at normal vital signs, someone that's been involved in some sort of traumatic event, what would we potentially be weary of if their vital signs look like that? So heart rate. So
Could be elevated.
yeah. So if we're looking at potentially over 100, 120, are they in shock, or are they compensating? Have they got a bleed or something like that? Respiratory rate.
Elevated.
Yep. So we might see that elevated. If we're above 24, might start looking at that, having a listen to the chest, is there any sort of chest involvement, that sort of stuff. SpO2, is this going to change at all? So if it's lower, especially if it's lower than that 90%, that's going to be concerning for us. GCS.
14 to 15 is normal.
Yep.
Less than that, you can-
Yeah, so anything below 14 we'll be a little bit concerned about, especially after an event like that. Blood pressure. What's that blood pressure going to indicate if someone's sick?
It's been high as well.
Yeah, it could be high, or it's probably going to
shock.
that's probably going to trend lower if they do have a bleed or something. So if we notice that their heart rate is increasing, their blood pressure is decreasing, what does that tell us?
They're in shock.
Yeah, or
Also get blood.
yeah, some sort of bleeding event. So whether it's a shock-related thing, so they've got the vasodilation, so your blood pressure drops, or whether they've got a bleed internally, externally. BSL doesn't really change too much for our traumatic events, and temperature. So as we know with our traumatic patients, we can kill a lot of patients with temperature alone. So that's something to be mindful as well, as making sure that temperature up to above 36.5. Hello, how you going?
Yeah, but I'm not here, sorry.
No, that's all right. Are you here after this, or?
No.
Okay,
Well,
that's all right. We'll catch up. All right.
I will. Continue, please. Bye, everyone.
I do apologise if anyone's watching this to my back to the screen, but hopefully you can hear me. You might have to treat me for a screen for this, because after a while, talk to them. So, all right, we've worked out that we're not really worried about them being, actual time critical based on the mechanism and our vital signs. So then we can have a further assess of, I guess, what's actually going on. So another thing we want to be mindful of, I guess, is spinal as well. So we want to make sure that we tick that box. Is the mechanism significant enough for them to have a spinal injury? And what sort of things might tell us that they might, there's risk there. So, I mean, if we look at, take out, if someone's come off a ski or been in a motorbike or quad bike or, been hit in the head and fallen to the ground and hit their head, we know those sort of things have potential for spinal injuries. What sort of symptoms or signs would we see in a patient that we might consider?
Don't you consider that everybody that's had an accident with that degree of trauma can possibly have pelvic and spinal injury anyway?
Absolutely.
And neck injury, so they're treated accordingly.
Yes, yep, so absolutely. So if the mechanism alone tells you there's a risk there, then yeah, we put a spinal collar on, we can put a pelvic splint on. Do you carry pelvic splints in your bag?
Yeah, we do.
Yeah, cool, excellent. So with those two, so we can put them on as precautionary. What sort of signs we might see in someone that, say they haven't had the big accident, but they're presenting, and what sort of things might make us think, oh, there's a risk there, just based on their symptoms, again.
They could have pain, they could have also no sense of feeling in their limbs.
Absolutely, yep. So pain in their neck, or anywhere down the spine, lack of sensation, altered sensation, you're right, absolutely, all those things, lack of movement, power, excellent, fantastic. So if we, and then we can decide, are we going to put the collar on, are we going to put the pelvic splint on based on that. With our pelvic splint, we predominantly use our pelvic splint more for precautionary than actually finding pelvic injuries. Like you do have the odd patient where you highly suspect a pelvic injury, but it's not often that we, I guess, see a lot of people with significant pelvic injury. So we put it on more precautionary because as you can appreciate, it can only tell so much. And when we look at a pelvis, it looks something like this. So this is the back of it here. If it's going to break, where is it going to break? Predominantly. Right down that middle, yeah. So that's going to be the weakest spot of it. So it could be a hairline fracture or something like that. So when we want to assess the pelvis, we don't go in and push down on their pelvis because that could open up, and then we have an open book fracture, which you might have heard of. We want to essentially just test their inner spring, because when we put the pelvic splint on, it's going to hold it together. So when we test the pelvis, just either side, pushing it in and up, and seeing if there's any significant movement there or pain or that sort of thing. All right, so we've ticked all the boxes for our trauma stuff. Now we're going to focus more on the injury itself. So we're going to assess the pain. What sort of questions are we going to ask for our pain assessment?
Where does it hurt?
Yep, where does it hurt? Yep.
What sort of pain is it?
Yep.
Is it a sharp pain, dull ache, etc.?
Yep, so describe the pain. Yep.
Describe the pain. I mean, if they don't have a head injury and their GCS is appropriate, then you could ask them, to give you a scale of pain.
Yep.
Again, I don't agree with that because everybody's pain threshold is different.
Oh, 100%.
So 1 to 10, I think it's really difficult in a trauma situation to assess.
Yeah, so we don't expect just because you've got 2 out of 10 pain that something's not broken, but at least we test your level of tolerance and say, well, at the start it was a 10 out of 10, we've given you some morphine or whatever, and now we're at a 4 out of 10, so we've changed that. So, but how much pain do they have? And we've gone to nanas on the floor with neck of femurs and things like that don't complain of much pain, but you can see that their legs are a lot shorter than the others. So, so everyone's pain tolerance is going to be different. So, where does it hurt? Describe the feeling to me. Show sharp, heaviness, all that sort of stuff. What else? And the pain score. So the severity, I guess, we're assessing.
Well, feeling.
Yep.
In the limb, whether you can feel this, feel that.
Yep. So assessing sensation. Yep. Absolutely.
Just their facial expressions too when you're touching them or something.
Yeah. Yep.
Whole body response, I suppose.
Absolutely, and especially with kids, it's very hard to ask these questions too. So we want to assess, what does their facial expressions look like? How easy are they to console? And then what is the difference between how they normally are to how they are now? So could that, do they look like they're in pain, or are they, is this abnormal for the child? Do you use pain mnemonics or acronyms or anything like the OPQRST or the dollar or anything?
Yeah, PQRST.
So although in a fracture we sometimes it's a little bit obvious, and this is more I guess pertinent to things like abdo pain and chest pain and things like that. But what is P? Provocation. I don't know if I spelled that right, but we'll say I did. So does anything make the pain worse? So this is a good one to test in when you do have someone that's presented they've got a sore arm. Well, if they've got a sore arm, what could it be? From following a trauma, was that?
From being a trauma.
Yeah.
Well, it could be fractures in here.
Yep.
It could also be bruising, deep tissue injury.
Yep.
It could be, transferring of pain from up here,
Absolutely.
in here.
Yep.
Lots of things could be nerve pain, because nerves damaged.
Yep, absolutely. So there's a whole range of things. So it's not simply, their arm's fractured. It could be muscular pain, it could be a strain, it could be a sprain, it could be referred pain, as you said, it could be nerve pain, it could be exacerbation of other issues, and it even could very well be a psychological response to the mechanism. So I've fallen hard on my arm, it feels strange, it must be broken. I think it's broken, of course it's broken, it's in pain. So when we look at provocation, does anything make the pain worse? So if they lift it up, does that make the pain worse? What about if just hold your arm nice and still for us, just go loose, and then if I lift it up, does then it hurt? So that could, again, it's not going to be 100%, but that could tell us, is it muscular or is it fracture? Because if it hurts when they lift it up, well, it could be either or, but if it hurts when we lift it up without them using their muscles, or doesn't hurt as much, it may tell us, okay, it sounds a bit more like muscular. Do you have the tuning forks at the Urgent Care Centre for fractures? No?
Even with the pelvic spleen, we don't have it. I saw it in ambulance.
Oh, okay, yeah. So the tuning forks we used to use on mine sites, so it's literally a metal tuning fork when you smacked it, and it vibrated, and then you put it where the pain is, and if it intensified the pain, it usually told us it was a fracture because it intensified it through the bone. So does anything make the pain better or worse? Q? Quality, so that's our describing. So how would you describe the pain to me? Sharp, ache, that sort of stuff. R? Radiation, yeah. So does it go anywhere else? Is it in the one place or does it go anywhere else? S? Severity, so that was our 1 out of 10. So a scale of 0 to 10, 0 being no pain, 10 being the worst pain you've ever felt in your life. What would you rate this pain as? And T? Timing. So is it there all the time? Does it come and go? Is it sort of a little bit there then increases? That sort of stuff. So what is the timing of it? And I'm not sure if you use the O, but the O is for onset. So when did it first start? Cool. So that's assessing pain, no matter what pain it is. And as I said, sometimes if someone comes in and their arms turn around the opposite direction or whatever, well, it's going to be obvious where their pain is and all that sort of stuff. But certainly a lot better when you're looking at it's the unknown. So then we're suspecting a fracture. Has anybody heard of Pill's duct before? I don't know if it's just been an ambulance or. So Pill's duct is just another acronym, and but do you have any other acronyms you know for assessing like musculoskeletal problems? So P is for pain, R is for irregularity. How feeling? This is really testing out my vocabulary. T. We're going to have to Google that one. So this is just gives us something to assess when we're looking at fractures or musculoskeletal problems. Sorry, I'll just get the T for tenderness. Yes, tenderness. So do they have any pain? Is there any irregularity in the fracture? So what would irregularity be?
reduction,
Sorry, say that again.
like when there's a hip fracture, reduction in there.
Yeah, absolutely. So when you're looking at neck of femur, there's shortened rotation, or their arm might be facing in the wrong direction, all that sort of stuff. That is stuff is irregularity. Loss of power or feeling or movement. So can they move their extremities? Can they feel their extremities? Is there any swelling associated with it? So as we know, swelling alone will cause pain. So swelling is a fluid shift which causes pressure, and that pressure will then cause pain. So swelling alone could be the cause of the pain. D for deformity. So how does it look? Is it look deformed? Uneven movement. So again, that's trying to lift your arm and sort of the bottom half of the arm doesn't go with it, or that sort of thing. Crepitus, you know what crepitus is?
It's
Yeah, so that's that grinding sound, so bone on bone action there. And then our tenderness. So is there any sort of tenderness throughout the limb or whatever the case may be? So depending on the location of the fracture, does it make the patient more time critical?
Yes.
Yeah. What sort of? Very good, Michael. What sort of fractures might be more time critical than others?
Pelvic fractures.
Pelvic fracture. Yep.
Yeah, arterial bleeds.
Absolutely. So we look at pelvic fractures. So any sort of we've got our femoral arteries that run through there. So sorry.
Iliac
And our iliac arteries. Yep. So a fractured pelvis alone can hold up to 3 litres of blood without us really knowing about it. So that is a concerning fracture. So if they've got a pelvic fracture, that's probably generally going to be a helicopter job because they need probably surgery in Melbourne for that. What else?
Fractured neck fracture.
Yep, cervical fracture. Why are cervical fractures a concern for us?
Run the risk of damaging your spinal cord from there.
Yeah, absolutely. So we've got our nervous system that runs all through our spine or spinal cord, which runs through our spine, our neck. And depending on where our injury occurs will depend on what could actually go wrong. So our main concern with cervical is because that's what controls our breathing and our heart rates and all that sort of sympathetic and parasympathetic responses, as well as feelings to your legs, arms, all that sort of stuff. So the risk of paraplegia and all that sort of stuff. So absolutely cervical. What else?
Still talking spinal, lumbar.
Yeah.
That
So we'll say that's yes. So we'll say cervical or spinal. Yep. Absolutely.
skull fractures.
Yep. So skull fracture. So no matter where it is, it's an issue really. So whether it's up here, whether it's a base of skull, that sort of thing. And if you remember, even just going back to first aid, they're talking about raccoon eyes and
That's true.
what's it called? Something sign.
It's a bruising on the master bones.
Yeah. So again, potential basal skull fractures when you got that, but that's a later sign as well. So you'd see that within probably an hour or a couple of hours. What else?
Rib cage.
Yep, so ribs could be an issue. Yep. So I mean, people do have fractured ribs and they live with fractured ribs for a while, but certainly if the mechanism has caused a fractured rib, then there is a risk of there being underlying damage there as well. Yep. What else?
hip fractures.
Yep.
Really dangerous in older people.
Yeah, so hip and femur as well. So again, that hip fracture could be someone that's, or even someone that's sort of younger and healthier, it could still be an issue, but certainly when we look at our older people, then we've got a huge risk there because of, already sort of a compromised and weakened circulatory system and all that sort of stuff. So those sort of things are making us think, yep, this patient could become time critical. With them alone, it may not be time critical. Obviously, things like, if they had these and the mechanism enough is probably enough to make them sort of time critical or potentially time critical. But there are obviously the risk with a lot of these, and especially your pelvis and your femur, are bleeding. So we don't die of broken bones, but we do die when the broken bone severs an artery and then causes us to bleed. That's what we die from. So we've considered that. And when we look at fractures specifically, we look at two different types of fractures. You know what they are?
Simple and complex.
Yeah, simple and complex, or closed and open. So you're on probably three different types of fractures. So you got your open and your closed, which is obvious. So does the bone protrude from the skin or does it not? Once the bone protrudes from the skin, then we've got a risk of infection on top of that as well. So we have to control the bleeding, we have to control the risk of infection, and we also have to control the fracture as well. And then our complicated fractures are generally when there's two or more parts of the bone that are broken, or bones that are broken close to joints and things like that as well. So our open, our closed, and our complicated fractures there as well. So we've done the assessment. We've looked at our Pills duct or any variation of that. And essentially, if you just remember your colour, warmth, movement, sensation, so testing all those things, then we're well on our way to adequately assessing this patient. We're going to treat them, so we're going to give them some pain relief. What do we think of the pain relief?
In the hospital.
In a hospital setting. Yeah.
Compared to.
Somehow, if it's about 3 equals, we can even give functional.
Yeah.
We start with some simple analgesic. Nurofen works better.
Yep.
It's anti-inflammatory.
Yeah. So we've got a number of different ways depending on the pain scale. The 10 out of 10 have some Nurofen, you'll be right, man. But using Nurofen with your fentanyls or your morphines, by all means, we could do that. So at least once the stronger stuff wears off, you're going to have that, hopefully the Nurofen or the paracetamol's taking the edge off as well. And as we know, obviously Nurofen being anti-inflammatory, it's going to reduce swelling, which is going to reduce pain as well. So we've treated pain. What else do we need to treat this patient with? What else are we going to do for this patient, I guess, depending on where their fracture is?
Sleep or immobility.
Yeah, immobilisation, because we know immobilisation and traction is what's going to do the best for this patient. So for leg fractures, I don't know if you still have some sort of traction splint in the ED.
Rim splints. You have those?
So which one, sorry?
The Zimmer splints, is that what they are? Where they can wrap around, keep it straight?
Oh, it's like similar to the vacuum splints and that sort of stuff. Yep. So simple stability splint. So depending on what it is, you might have these formable splints here. They're good for arms. I mean, they're all right for legs, but they're more good for arms and sort of small bones and that sort of stuff. Or you've got your like your either your air splints or your vacuum splints. So they work the same way. They just hold it in place. And then generally for leg fractures, we look at using a traction splint. So if you can appreciate that the most pain in a fracture, and then obviously you've got your nerves and your blood vessels and that sort of thing there. The biggest pain for fracture is because that jagged bone is rubbing against that jagged bone, and it's affecting the nerves all the way around it. So that's why someone's feeling pain. So with a traction splint, and they used to be called Donway splints, we now have CT6s. We essentially secure the splint up here and secure it to your ankle, and then we traction to remove that bone from this bone. So we actually traction it, and generally we try and traction it to the same size or a little bit more than the other one. And so what that does is pull those two bones away from each other, and hopefully will reduce the pain. And it's amazing, you do see a lot of femur fractures, and you load them up with all this medication and penetrating, and they're still screaming at you, and then you finally get traction, and then it's stop. I've got a 12-year-old that fractured his femur up at a playground. We gave him all the pain relief in the world, and he was just screaming. Got the CT6 splint on, tractioned it, and it was almost instantaneous. He just stopped crying, like it was good. Obviously, bumps and all that sort of stuff made it a bit worse transporting, but for the pain relief, it all comes down to the traction as well. But if you don't have that ability for traction, just considering the your simple pain relief, your pain medications, your immobilisation, and then reassess from there as well. Yeah, and then obviously you got the added ability to when it is here is looking at X-rays as well as I'm assuming you do some sort of if you do like casts, can you do casts and things here as well? Yeah.
You do have fiberglass.
Yeah, cool. Yeah. So that's obviously this is your initial care, and then that's looking at your more definitive care and what you do with the patient from that point on. But I mean, if we look at our trauma, we look at our history, Now, potential for the patient being time critical or numbers telling us that the patient is actually time critical. We consider what's a major fracture and what's not. We do an assessment of that fracture using either pill stack or color, warmth, movement, sensation, and then we treat them for that. Whether we treat hemorrhage control or pain or whatever the case may be, and that's good times. Any questions?
So what about leg roll and travel roll? Do you
For
cervical fractures or sometimes we do that or it's something you use the towel to put it.
Oh, so when you're looking at spinal injuries, yeah, absolutely. So, have you got soft collars here?
Yeah, we do have different, a couple different sizes, but sometimes
Yeah.
it doesn't work. So
Yeah, so we still use hard collars, but hopefully this year we'll be transitioning to the soft collar. I think it might be similar to yours, like a two-piece sort of. It's a rigid, but it's not a hard, rigid collar. At the end of the day, this doesn't stop someone from moving their head. It reminds them not to move their head. So when someone doesn't tolerate that, then we use 2 towel rolls, or you can either roll up 2 towels and put on their side, or you can just use a blanket, fold a blanket, put it under their head, and then roll it inwards. Actually, sorry, no, tell a lie. The blanket you roll
towards,
towards, but sort of underneath, so it doesn't unroll. Yeah, so use
put
it
it
like
underneath, isn't it? So that's why I had trouble. When you put it just slowly rolls up.
Yeah.
So you put a tape or just.
So you can put a bit of tape. So in the ambulance, we have 2 towel rolls that are already taped and ready to go.
Yeah.
But if you don't have that, you can a blanket. I'll use my makeshift blanket here. And then for slings, how do you feel about slings? Confident with slings? Good on that. So you put that under the patient's head, essentially there, so with the blanket underneath, and then you roll it underneath, so it doesn't unroll like that. And then same with this side, and then you can put a bit of tape there as well to hold that in place. You can put a bit of tape over the patient's forehead as well to hold that in. Or if you just had 2 standalone towel rolls there as well. So again, it's all about reminding them not to move their head more than anything.
Well, yeah, I was taught that with someone that's in that stage, that post-traumatic stage, that something to focus on here, if you're predominantly suspecting spinal injury or cervical injury, having the finger there and tapping reminds them they're focusing on that.
Yeah, okay.
And whilst you're doing that, you're saying, remember, focus on this, don't move.
Yeah.
And they keep focusing on that. I was actually, my brother's a micer and he taught me that.
Yeah.
He said it's something he does.
Yeah, good.
Keeps doing that.
Yeah, that's a really good thing too, because you can't move your head, you're just trying to do that.
You're focusing on that.
If you don't have their attention, the first thing they want to do is either look around or, do you have any pain?
That's what he said. That reminds people.
Yeah.
That you're there.
Yeah.
And that you want them to do a certain thing.
Yeah, it's a good one. I like that.
It's really interesting when you taught me that.
Yeah, that makes sense, absolutely. Yeah, it's good. Thanks for sharing that. And then with your sling management, again, I'm not great at slings, but you got simple slings. Just a simple arm sling is, the point of the close your arm. Is that all right? So just put your arm like it's been broken. Bring that underneath. So the point of the triangular bandage to the elbow. These are the worst triangular bandages. In there, tying it up there, depending on what you want to achieve depending on where it is. So that's just a simple arm sling. Obviously, it could be a little bit tighter as well. Or you've got your collar and cuff sling. So collar and cuff is it could be shoulder injuries and things like that.
I think we runs scapula.
Yeah. Geez, now I don't remember how to do it.
We have that ready-made.
Oh, do you?
That's
we use
foam
the-
thing.
that's
It
right.
comes in big rolls.
think I've done it right.
You used to use it on some of these.
So you do a P and then a Q. Is there a way to do this?
Uncomplicate and do an arm.
Yeah.
Around.
Oh, that's not going well.
I think the ones we have.
Oh, yeah, that was all right.
Yeah,
Yeah.
that's good. Well done.
So
And
then you can say we've got the fractured shoulder or whatever. Bring that up. Tie that up there. Again, the height at which you tie it will depend on where the position of comfort is, but at least that stops his moving his shoulder there, so that's going to reduce the pain a bit as well.
Is there a specific height that it's better at, or is it simply related to the degree of the fracture?
Just more the position of comfort really, yeah. So you might be able to knock it out that high because of the injury, depending on what's actually broken or whatever, or you might be able to get it up all the way. It really just depends on the position of comfort more than anything. So in all circumstances, you're really just trying to stop movement there. So whichever way you can do that, yeah. So a P and a Q. I'm not going to be able to do it again. That's right. I don't know. Just wrap it around their arm twice. Simply like this. Job done.
yeah, that's right.
I just wanted to look smart and I failed.
They used to, if you didn't have a sling, just pull your top up.
Yeah, absolutely. So roll your t-shirt up or undo it.
Yeah,
There
yeah.
Just something simple like that. You know, newspapers, sticks, things like that.
Yes.
And even like for a collar and cuff, you could literally just up in there. Really, and that sort of
That's right.
holds it to an extent and you've got the top button. Job done. So absolutely.
Excellent. Use RICE, isn't it? Rest, ice, compression, elevation.
So yeah, for our soft tissue injuries, rice or using cold packs or warm packs, depending on what it is, so muscle strains or sprains, depending on that sort of stuff. But it really comes down to immobilization. So when we look at the RICE principle, it's rest, so not aggravating it. Ice will reduce swelling, which will reduce pain. Compression, so a compression bandage will reduce swelling and reduce pain. And then your elevation, again, if you're elevating it, there's less blood flow, there's less swelling, there's less pain. And then R for RICE, R for refer, so refer on to.
So with compartment syndrome.
Yep.
Is that something that can be at the time with a bad fracture, or is that going to be in hospital?
So that's going to be generally later on. So that's when compartment syndrome obviously is an issue when there's lack of blood flow to an area. It's very much similar to your crush injuries. So whether something's broken here and you've got no blood flow there, or whether something's landed on here and it's stopping blood flow, very much like a tourniquet effect. And so what the risk is that when cells get less oxygen and that sort of stuff, they start to release things like chemicals like potassium. And the risk is that once you release that and there's a build-up of potassium, the potassium is going to come back through, go into your heart and then cause electrical disturbances and put you into arrhythmias there. It's probably not a huge concern as much as it once was. And again, for an arm, it's not too bad. For a leg, it's probably more so. The other risk too is if you've got something that's landed on, their leg and it's causing a crush injury, yes, that potassium that is a concern. However, the risk is it holding it, is it its own tourniquet? So once we release that crush, is their blood going to start to flow back there and gravity and going to drop their blood pressure? Or have they got an uncontrolled bleed in their femoral artery because of the injury or something like that? So there's a few things to consider. So it used to be, if a crush was in place when we got there, we'd leave it. We'd get intensive care paramedics up. They'd give sodium bicarbonate, which neutralizes the potassium, and then we release it. Now, if it's been less than an hour, the instruction is to release the crush. So less than an hour, release the crush. If you had some IV lines with some fluid done up, ready to go, even better, just in case to replace that volume. But so very much similar process with compartment syndrome. It's probably more a long-term effect where you've got, prolonged lack of circulation.
Yeah.
And then you get that, the issue of, the risk of rhabdomyolysis where the build-up of toxins and that sort of stuff being released back in the body. Yeah.
We have one, I'm not going to extend that, but we have one patient with history of rhabdomyolysis.
Yep.
Yeah, so in acute room 6.
Oh, yeah.
So just So when she had a fall, or even if a bruise can cause that, release of toxin and cause renal damage. Anyway, thanks.
Yeah.
Thanks, Josh.
Thanks, Josh.
No worries at all.
Thanks,
Amazing.
Yeah.
Appreciate it.
Thank you.
Excellent. Thanks, guys.
Information.
Thank you very much.
Yeah, thank you.
Right, then.
Thanks, everybody.